Our osteoporosis for primary care is by Dr. O'Connor. She is an associate professor of medicine, Division of General Internal Medicine at University of Washington. Welcome, and thanks very much.
Thank you. So somebody waved, but I don't know if I know, with the masks, I can't tell if I recognize people. Yes, I see you, I know you, yes, wonderful. Well, thanks everybody for being here. I know it's absolutely gorgeous outside, so I really appreciate you being here. I know that is hard when we don't get these days very often. And it is a pleasure to be back here in person, and I was realizing that I think this is the first talk that I've given in person in the last couple years, so it feels a little bit odd to be up here, but I'm excited about it. Woo! Please let me know if I'm talking too fast or if you can't hear me. It seems like this microphone's working okay. And then I think we're saving questions for the end, is that right? Or are people speaking up? If something comes up in the middle, feel free to ask. Otherwise, we can save questions for the end, whatever works best. So, as you heard, my name is Kim O'Connor, and I'm a general internist, primary care physician at the University of Washington. And I really wanted to approach the osteoporosis topic from a primary care perspective, like in the trenches. How do we make these decisions? What medications might we feel comfortable prescribing? When should we start thinking about referring to our endocrinology colleagues to get help? Just really thinking about, gosh, what do we do? Because there are a lot of new medications out there, and it can be a little bit confusing figuring out what may be right for what person. So, what we're going to do today is we're going to talk about whom we should be treating, think about some of the medication options, the anti-resorptives versus the anabolics, how long we should be treating, and I think this last piece, consolidation therapy, is something that I really just recently learned about and is so important for us to be aware of as we are starting to think about using some of these new medications for the treatment of osteoporosis. So, I am a fan of doing cases so that we actually keep our brains awake, because I know it's hard sitting in a room all day. I know there's no audience response, so you can either raise your hand or you can just think to yourself how you might answer this. So we have a 55-year-old healthy Japanese-American female. She's requesting osteoporosis screening. She has a 5-pack-year history of tobacco. She quit 10 years ago. She has not had a fracture. Her mom had osteoporosis, but no fractures. She's 5'4", weighs 128 pounds, and has about a glass of wine per night. So what would folks recommend? Do they want to do a DEXA of the forearm, use the FRAX calculator to determine need for screening, or screen with a DEXA of the hip and spine? So I heard some B's. So FRAX, great. When do people get the DEXA of the forearm? Just out of curiosity. This was a sort of interesting teaching pearl for me that I learned from the endocrinologist. Clearly, if somebody has had bilateral hip replacements, it's helpful to have a forearm DEXA scan. But in somebody with hyperparathyroidism, they might present with osteoporosis only in the forearm. So that's the time. If you're concerned about that, make sure that you're getting a DEXA of the forearm. So I agree. I would use the FRAX calculator to determine her need for screening. Who here is using the FRAX calculator for something? So actually not a few people, but not too many people. This is actually a really helpful tool. So the FRAX calculator can be used in 2 ways. For this case, I'm using it to actually convince her not to get a DEXA scan at this point. But you can use it to also determine if somebody under the age of 65 might benefit from earlier screening. We can also use it to decide if somebody may be a candidate for treatment if they have osteopenia, and we'll talk about that in a bit. So most of us are pretty comfortable with the screening recommendations, and I'm really going to focus on the treatment of women in this talk today. So most of us are comfortable with the USPSTF and other recommendations to start screening women, postmenopausal women after the age of 65, regardless of risk factors. Between the ages of 50 to 64, you could screen if they had 1 or more risk factors. And on the bottom here, I've listed the risk factors for you. So whether do they have a fragility fracture, are they on glucocorticoids, first-degree relatives with a history of hip fracture, are they thin, are they actively smoking, or do they have pretty high alcohol use? So in that case, 50 to 64, you might screen. But I think with a lot of us, we're really trying to think about the Choosing Wisely campaign and trying to not do tests when it may not be necessary. So using the FRAX calculator can be really helpful to convince patients that, you know what, I don't think you're high risk enough yet. Let's keep using this calculator till you hit 65, and we might do it early, but we may not need to. So here's what the calculator looks like, and you can plug all of her numbers into it, which I did. You'll see on number 12, there's a place to put in the femoral neck bone mineral density. When you're using it for this clinical question, you don't have to put anything in there. And then at the bottom, you look at the 10-year probability of risk of fracture, and it breaks it into major osteoporotic fracture or hip fracture. If your major osteoporotic fracture risk is greater than 9.3%, then that is equivalent to a 65-year-old white woman, which is what they used for the screening recommendations at baseline. Okay, so I could tell her, gosh, you're still pretty low risk. Let's hold off. We could do this every few years until you hit 65. We'll screen you if we need to early. So we've gotten our baseline bone mineral density scan for our patients. Let's assume these patients are over the age of 65. The next question that comes up every year at their preventative health visit is, should we repeat it? And that's, hasn't been a super easy question to answer, and there's not a ton of data to tell us what to do. But this was sort of a helpful study where they looked at 5,000 women over the age of 67 who had baseline, who did not have a known history of osteoporosis or fractures, got a baseline DEXA scan, and then they followed them for 15 years. And what they tried to determine was how long would it take before 10% of these women developed osteoporosis and started treatment before getting a fracture. And assuming these patients are not at accelerated risk for bone loss, like not on prednisone or some other medical condition that may increase their risk, if they had normal or mild osteopenia up to a T-score of minus 1.49, you could probably wait 10 to 15 years to repeat it, which is a lot longer than I think most of us are probably doing, right? Moderate osteopenia, maybe recheck in about 5 years. Advanced osteopenia or at accelerated risk for bone loss, that's when we want to repeat them more frequently, depending upon how high risk they are in 1 to 2 years. And then clearly if they have osteoporosis, we're going to be talking about whether treatment is appropriate or not. All right. So now, how do we decide how we're going to treat? So the recommendations really differ based on how high risk the person is. So we're going to talk about how to divide somebody into low, moderate, high, or very high risk. So that's the first question you want to ask. The next question you want to think about is there any contraindications or adverse effects that they may not tolerate? Are there any secondary benefits? And then clearly we always need to think about costs, route of, and frequency of administration. Can our patients handle how frequently they have to get this medication? So you want to think about whether, there could be a secondary cause. I think, obviously we're all aware of the glucocorticoids and trying to address that if they don't need to be on them or can be on less, good. Initial lab testing, getting a chemistry panel, taking a look at their calcium primarily, checking a vitamin D level, looking for any underlying liver disease, anemia, something that might suggest a multiple myeloma or maybe a malabsorptive condition. And then based on history, physical exam, lab studies, you may have to do additional workup, especially if you're concerned about any of these list of conditions below here: thyroid disorder, celiac, inflammatory bowel disease, primary hyperparathyroidism. Certainly if they were hypercalcemic, you would worry about that. All right, so now we're at the point of determining somebody's fracture risk. So low risk means no history of fractures, normal T-scores, and a FRAX that is not suggesting they are high risk, and we'll talk about that in a second. Moderate, no history of fractures. Their T-score shows osteopenia, and their FRAX calculator score, again, does not suggest they're particularly high risk. I think in most cases, we're not going to treat moderate risk people, but you could consider it. High risk, this is what most of us deal with in our clinics, right? So folks who've had a prior spine or hip fracture, they have osteoporosis on their DEXA scan, or their FRAX risk is high. So that same calculator I showed you before, this time you would put in the T-score for the femoral neck in that last number 12 question, and it'll spit out these numbers of your 10-year risk of a hip fracture or other site fracture. If your hip fracture risk is greater than 3% or your other site fracture risk is greater than 20%, you may be high enough risk to consider treatment. And then very high risk is severe or multiple spine fractures or a really bad hip fracture, which kind of all hip fractures are bad, but some are worse than others, and osteoporosis. And so these last two categories, I think we need to really be thinking about treatment. So I get in trouble every time I give this talk if I do not bring up lifestyle measures. Everything that I'm talking about, I focus on medicines because I think most folks are pretty comfortable with these recommendations already, but just a reminder, trying to get adequate calcium, ideally through your diet because you absorb it better that way, making sure you're getting adequate vitamin D, repleting it if it is low, encouraging some kind of exercise at least 3 times a week, address smoking, address alcohol use, and then I think super important for all of us is to think about fall risk, and is there anything we can be doing to decrease fall risk? All right, so mechanisms of action. So there's 2 primary mechanisms of action. Something is either an anti-resorptive, which slows bone turnover, decreases reabsorption. This is bisphosphonates, denosumab, estrogen, and SERMs. The other category is the anabolic agents, which stimulates bone formation, and that's the parathyroid analogs, or romosozumab. So now we know we want to treat because they're high risk or very high risk. What's the next step? Consider your contraindications, what adverse effects might come with the medication, and how it's dosed, all right? So for bisphosphonates, most of us are quite familiar with avoiding these medications, at least the oral formulations of bisphosphonates in folks with severe GERD or esophageal conditions. A lot of these patients will tolerate the IV formulation, so remember that. And then severe periodontal disease and a low EGFR less than 30. For denosumab, we want to consider the periodontal disease as well. Some risks of osteonecrosis of the jaw with denosumab as well. For parathyroid analogs, a little bit of a higher GFR, but less than 40 is contraindicated. If people have severe hypercalcemic conditions, might avoid it in those patients. And then this does require daily injections. Romosozumab, I'm going to start calling it Romo because it's too hard to say that every time. So Romo, contraindicated if you're at high risk for cardiovascular events. Most of us are comfortable with the contraindications for estrogen. And then SERMs, similar, VTE risk, stroke risk, hot flashes. And then last piece there is, are there any secondary benefits? And I would say of these medications, really the one that has secondary benefits may be a SERM if you're at high risk for ER-positive breast cancer. So this is another piece that I think is important to think about ahead of time. Not all medications treat or decrease fracture risk at all sites. They all decrease fracture risk at the spine. So bam, whatever one you choose, you're going to be able to treat the spine bone mineral density and decrease fracture risk. Really most of them, some of them we know for sure, decrease fracture risk at the hip. We're talking about bisphosphonates and denosumab. And the new parathyroid analogs and Romo have a trend toward decreased hip fracture risk. However, they just are new enough and hip fractures are so much less common that there's just not enough data, but there's a trend toward treating. And then SERMs don't work at the hip, and so just remember that if somebody's got primarily hip osteo, then maybe that's not a good choice for that patient. So this is the concept of consolidation therapy. Is anybody familiar with this? Does anybody have this sort of go off in their head like, oh goodness, I have to think about this before I start treatment with osteoporosis meds? I'm just curious, this was super new to me. So if you don't know, don't be surprised, all right? So I think most of us know that bisphosphonates, when you discontinue bisphosphonates, they very, very, very slowly go out of your bones. So it's okay if you're off of them. It's okay if you miss doses because they leave your bones very, very slowly. But all of these other medications, as soon as you stop them, you have a very rapid decline of bone mineral density over the next year. And in some cases, especially with denosumab, that can be very harmful, and we'll talk more about that. So if you are not using a bisphosphonate, you have to be thinking downstream. You can't just have a conversation about the first medication. You have to be thinking downstream, what is going to come next when I stop this medicine or when they have a side effect and they decide to stop this medication. Because if you just stop it, we may be causing them harm. So here, here's a list of all the medications and the length of time most of them are used. So 2 years for the parathyroid analogs, 1 year for Romo. Denosumab, it's kind of controversial, maybe lifelong, maybe 10 years. SERMs, we usually stop when their risk of complications from the SERMs start exceeding the benefit, same with estrogen. And you either need to transition to another medication for a period of time and or consolidate with a bisphosphonate. So all these meds eventually have to be consolidated with a bisphosphonate. So if your patients cannot ever get a bisphosphonate and or refuse to ever get a bisphosphonate, you need to think long and hard about whether you're going to actually start any of these other medications. So how do you consolidate? So I tried to make this a little bit less complicated, but the idea being, so let's say we start with parathyroid analogs or Romo. After your 1 to 2 years of therapy, there's lots of different ways you could go. You could maybe go to estrogen for a little bit if they don't have contraindications, or you could go to denosumab for a bit, and then on to a bisphosphonate, or you could go straight to a bisphosphonate. And again, that's going to matter in the clinical context of your patient. But eventually, when you get to that bisphosphonate piece, it kind of matters when you give it. So you don't stop it and then immediately give it. So if you're going from denosumab to a bisphosphonate, you have to wait at least 8 months to give that medication if it's IV, and 6 months after discontinuation if it's oral. And in an ideal world, I know a lot of our endocrinologists actually use the bone turnover markers to try to decide if it's time to start them on it, but if you may not have access to those, your insurance may not pay for them. So just remember, 8 months after stopping denosumab for IV, just 1 dose, and then 6 months after stopping denosumab with oral for 1 year of therapy. If you're going from the parathyroid analogs or Romo, you can start it earlier, like around 3 to 6 months. Okay, but I know it's complicated, all of this, so save this slide so that you can look back at that, because I'm never going to remember that. I need to go back and look that up, right? Yeah. That's a very good question. So I'm sorry, so what if you can't use a bisphosphonate down the road? That is a very good question, right? So those are patients that you might be putting them on estrogen. You might be putting them on a SERM or something else that isn't a first-line agent that they may be safer with than having to go down and hopefully be able to stay on it long term. It's a tough question. Like, this is where, as a primary care provider, I don't do this enough, that if I come up with that question, I'm getting endocrinology involved. They can help me with that, answer that question. Yeah? Yeah. Why did you do that? Right. I mean, I think the point being, I will tell you, I don't prescribe all of these medicines, right? There's some that I'm comfortable with and there's some that I'm not. I think what's important for us as primary care providers is to recognize when we have patients that might benefit from something besides a bisphosphonate first. And if we are not comfortable with that, that's the time to refer on and just get those questions answered. I think it's just that I want people to be familiar with these medicines and to know when to ask for help. I'm not comfortable with all of them, but I'm comfortable knowing when to refer now. And I think that's really probably the most important thing for us. Is that okay? Oh, yes.
I'm sure I probably learned this at some point, but I forgot there was IV bisphosphonate.
Yeah.
Is that an infusion center?
It is an infusion, and I'm going to talk about bisphosphonates, and when I talk about that, can I address that question? Okay. Good. Yeah. Yeah, I think the longer you're on it, the more bone mineral density gains you've had, so the farther you have to fall, I guess is how I would think about that. Okay, back to this one. So, going again, treatment based on fracture risk. So low risk patients, we probably shouldn't be treating them, right? Moderate risk patients, probably shouldn't be treating them. So we're in the high and the very high risk. For our high risk patients, which thankfully is most of our patients, bisphosphonate or denosumab is really your first line agent. For very high risk patients, these are the multiple spine fractures or really bad T-scores. This is when I think we should be wondering if they should receive a parathyroid analog or Romo first, okay? All right, sorry, I'm getting dry up here. Okay, so you're seeing a 65-year-old woman with osteoporosis, T-score minus 2.8 in the spine, minus 2.7 femoral neck, family history of breast cancer in her grandmother at 58, no other medical problems, 2 falls in the past year, no fractures, EGFR 58. All right, so patient is concerned about an osteoporotic fracture. Which of the following would you recommend? Raloxifene, abandronate, teriparatide, or alendronate? Or no treatment, calcium vitamin D. All right. I'm actually going to argue alendronate for this patient, okay? So this is a person who's at high risk, not very high risk. They haven't had a fracture, their T-scores aren't horrible, and their GFR's okay. So one question is maybe then why not abandronate? And we're going to talk about that in a bit. I prefer alendronate over abandronate because of fracture reduction data, especially at the hip, okay? Raloxifene, not gonna help at the hip. We know it helps with the spine. And teriparatide, because they're not very high risk, I wouldn't start with that. All right, so we're gonna talk about very high risk patients first. So we already sort of defined what that was. So these are the folks you think about an anabolic agent first. And again, I am gonna beat this in everybody's heads over and over. Think about your downstream plan before you start it. So consider contraindications for the parathyroid analogs. If their GFR is less than 40, avoid. Otherwise, fairly minimal side effects, but it does require daily injections. And then Romo has a black box warning against using in folks who are high risk for cardiovascular events. So the parathyroid analogs, they are parathyroid. So we know that excess prolonged exposure to high parathyroid levels can actually cause osteoporosis, but short-term or intermittent exposures can actually build bone. So your bone mineral densities go up pretty quickly, but it takes a little bit longer to have the fracture efficacy. And then the benefits run out after about 2 years, 18 months, 2 years. So one of the reasons why you stop at 2 years. Now, ideally, if you could get insurance to cover it, you would put somebody on a parathyroid analog before a bisphosphonate because the bisphosphonates can blunt the effect. And again, following it with some kind of transition to other therapy or bisphosphonate. So what limits the use of this? Cost and the fact that it is a daily injection. We talked about the low EGFR, and that's primarily because as we get chronic kidney disease, we often get secondary hyperparathyroidism, and so we wouldn't want to be double dosing them with parathyroid, essentially, is the reason. Adverse events are rare. If somebody has, multiple kidney stones, or maybe they have sarcoid and their calciums at baseline are high, you might avoid this. If they've got really bad to hard to control gout, may not be a great medication. Might cause some headaches, nausea, some orthostasis, so often they recommend first dose given in the clinic to make sure you tolerate it, and then stopping at 2 years, primarily because it stops working, but also some animal studies suggest maybe osteosarcoma with long-term use. So there's teriparatide, abaloparatide. They decrease fracture risk by about 75 to 85% at the spine. Still need more data for the hips, but are trending toward fracture reduction. These are covered by Part D in some cases, Part A and B in other cases. They can obviously be quite expensive. I have not prescribed this on my own. I have sent my patients to endocrinology and they've received this, but this is when I'm a little bit conservative. I walk into trying new things. It takes me a little bit of time. I'm almost there. I'm not quite there yet, but I know when to refer. Same with Romo. I have not prescribed this. So Romo, monoclonal anti-sclerostin antibody. The duration of treatment for this one is a year, followed with a consolidative therapy. We talked about the FDA black box warning. Could be potentially quite risky if you are at high risk for cardiovascular disease. The fracture reduction is about 75%, similar to one of the parathyroid analogs. This is a monthly injection. This one needs to be given in the office as Medicare Part B. Our next patient, 70-year-old woman with a spine T-score of minus 3.5, hip T-score minus 2.9, history of debilitating compression fracture 4 months ago with minor trauma. She's got diabetes, hypertension, low back pain, severe hand arthritis, normal EGFR, no history of cancer or DVTs. So what med would you consider for her? Alendronate, denosumab, raloxifene, or teriparatide? All right, so this one's a little trick. I'm going to say denosumab. I consider this person very high risk, so I actually think teriparatide would be the right answer, but it's daily injections and she has severe hand arthritis. So she might not be able to handle that. So I threw that in there just to trip you up a little bit, to just make you remember you have to think about all these pieces as you're making your decision. So in this case, maybe denosumab would be our next best choice. If Romo were on here, that might be an option for her, but I didn't give you that as a choice. So into the high and moderate risk patients, again, probably not treating moderate, but our high risk patients, history of fractures and osteoporosis, but not terrible fractures or terrible osteoporosis. So this is where we're pretty much going to decide between denosumab or bisphosphonates. Estrogen and SERMs are really not first line recommended agents, but that is an option. So again, consolidated plan down the road. Again, thinking about contraindications, remembering to ask them about their dentition if you're going to use denosumab. We already know all the bisphosphonate risks, the estrogen risks, and the SERM risks. So making sure, and she seems safe, from all those standpoints. So denosumab is an anti-resorptive monoclonal antibody, inhibits osteoclast formation, helps inhibit resorption, So it works about 70% reduction at the spine, 40% at the hip. It's a Q6 month injection covered by Part D and Part B. And this is a nice one. If somebody's been treated with bisphosphonates already, you can use this one after. It doesn't seem to be blunted by that. And this one is okay to use in renal insufficiency. So it might be that patient, if we think they could be on denosumab forever, that might be the treatment that comes after one of those other anabolic agents, but we'd have to be pretty confident with that. So, treatment is usually limited by cost and the risk of rebound fractures, which we will talk about. Otherwise, adverse events are rare. Musculoskeletal pain, some hypercholesterolemia. If they're at high risk for hypocalcemia, chronic kidney disease, vitamin D deficiency, you need to be more careful, make sure those things are replete, and maybe check some follow-up calcium levels shortly after starting treatment. I think at first we were really scared that these were going to exacerbate underlying skin conditions and cause cellulitis, but the risk of that is minuscule, like less than 1%. And then question about whether it may affect the immune system or increase risk of other infections. And then osteonecrosis of the jaw. There are some case reports out there with denosumab for that as well. So how long do we treat? So when this medicine is stopped, bone mineral density kind of plummets. It can get back to baseline within a couple years. There is about 10 years of safety data, but we are starting to see the case reports of atypical femur fractures and osteonecrosis of the jaw. And I think this is the piece that makes me really hesitant about this medication. And again, you've got to really have a clear conversation with your patient before starting this medicine, is that there's emerging data that when this is stopped, fairly quickly, within the year, even a month or two after missing your dose. Remember, it's dosed every 6 months. So if they come in at month 7 or 8, even those 2 months of missing it, they can have rapid enough decline of their bone mineral density that they can get multiple spine fractures. And so it's a big deal. And so when we think about COVID, right, there were a lot of patients that started on this medication and they were hesitant to come into the office to get their injection. And we could have caused them harm. And I don't think we knew as much as we do now about that, but just really be aware, like, you cannot miss your dose. If you want to stop this medicine, you must come back and have a conversation with me earlier rather than later so we can decide what we're going to do next. I don't actually know that's a good question. I don't actually know the answer to that. That's a really great question, though, because it's probably they're going to have that secondary benefit of the slow decline from the bisphosphonate. It probably would depend also how long they'd been treated with the bisphosphonates, but I don't know the answer to that. That's a great question. I'm sorry, I'll repeat it. I'm sorry, I'm bad about that. Was that data of the fracture risk in patients who had been pre-treated with bisphosphonates? And I said I don't know the answer to that, but that's a great question because the bisphosphonates leave the bones so much slower that maybe the risk may be different. Okay, 68-year-old woman with spine T-score of -3.2, hip T-score -2.5, history of several compression fractures, chronic kidney disease, EGFR 38, significant GERD symptoms on PPI, no history of hypertension, cardiovascular disease, DVT, diabetes, interested in starting a treatment for osteoporosis, secondary workup was unremarkable. So, alendronate, raloxifene, abaloparatide, Romo, what's our thoughts? So this is where Romo might be a good option, right? I think abaloparatide would also be a great option, except for the EGFR is under 40. But otherwise, I think either one of those would have been a good option for this patient. All right, so we're moving into bisphosphonates. Here you see that all of them work well at the spine with the most fracture reduction with IV reclast or zolendronate, and then most of them work at the hip. But this is the piece where I don't choose abandronate, which is kind of a bummer because it's Q3 months oral, which is great, right? Because taking oral bisphosphonates is not fun. But there's not enough data right now that it decreases fracture risk at the spine, so I'm avoiding that one. And then these are just some different doses they come in, daily, weekly, monthly, and some of the costs. So when we're counseling our patients about taking bisphosphonates, when it's the oral bisphosphonate, we want to remind them to take it on an empty stomach in the morning. There's improved bioavailability in the fasting state, but interestingly, the morning time also seems to be important. If people fast at other times of the day, for some reason it still seems to have better bioavailability in the morning. Take it with lots of water. We know to tell them to sit up for 30 minutes so they don't get a pill esophagitis. And actually, coffee, juice, tea can decrease absorption, so it really needs to be water. For the IV zolendronate, avoiding if the GFR is low, and counseling your patients that about 10 to 20% of patients will have a flu-like reaction day of or day after the infusion. But pre-treating and taking for the next day either Tylenol or an NSAID, that can actually help. The other thing that I've learned is that it can trigger some hypotension in patients as well. So telling them to stay hydrated, if they're on a diuretic, you might have them hold it for a day or two if that's safe for them to do. So just to be aware of that as well. And then the risk of hypocalcemia. So before they will infuse this, you have had to have labs fairly recently. It's actually, I think, within 3 months, but and to make sure that they're not hypocalcemic. And you want to make sure their vitamin D is replete as well. Also because the bisphosphonates, none of these medications work as well if you have vitamin D deficiency. So repleting your vitamin D is important. And so I think the question was, where is this done? At the University of Washington, this is one that I have moved toward prescribing. And I was hesitant because I thought, this is going to be hard. I'm going to be doing all these prior auths. And And surprisingly, I have not had to do any. And so we have an order set in Epic now, and it's pretty easy to order. And it has a whole list of recommended labs to check and when, and it gives you the pre-treatment with Tylenol and all of this stuff. And it's done at University of Washington in an infusion center at the hospital. And I've really not had any trouble with that. And so, and it's usually redosed every 12 to 18 months. Has anybody else been prescribing this? Did you have trouble with it at all, or? Yeah. So this is one I think, most of us are pretty comfortable with bisphosphonates. This might be our next step, right, to foray into the IV formulations of this. And patients like it because it's easy, right, than having to take a medication once a week. So counseling our patients about the osteonecrosis of the jaw risk, again, it's a quite low risk. And then there's certain patient populations who are much higher risk. So do they have poor dentition? Are they on steroids? Are they going to get invasive dental procedures? Those folks I'd be really worried about. But I will say, talking to our oral surgery colleagues, they usually only see this occurring in people who are on IV bisphosphonates that are dosed for treatment of metastatic cancers. So the doses we're using for osteoporosis are still pretty low risk. But it's almost never urgent to treat osteoporosis, right? So if they need to go get their dental procedures done, get them done first, and then get permission from the dentist or oral surgeon as to when you can start these. If they're already on them, there's not a lot of great data to tell us what to do, but depending upon how long they're on them and if they are on steroids or not, you might hold them for at least a couple months. And I just think talking to our dental colleagues is important to come up with a plan. So the dreaded atypical femur fracture. So we all know about this, and it is scary. And again, I think this is an opportunity for informed consent when we are speaking with our patients. So prolonged use of bisphosphonates, usually over 5 years for oral, 3 years with IV, is associated with an increased risk of an atypical femur fracture, so sort of mid-shaft fracture. However, it's simultaneously associated with a decreased risk of typical fractures, which is why they're on this in the first place. So you really need to think about how high risk are they for a fracture. So whenever I start a patient on a bisphosphonate, I tell them at 3 or 5 years, depending upon the formulation, we need to take a time out and have a conversation. And I want them to put that on their calendar, and I put it in my problem list, the start date, so I don't forget. And at that time period, we pause and we think, are you still so high risk that we should keep you on this for longer, or can we maybe take a drug holiday? This helped put it into context for me. I mean, I was scared of the atypical femur fracture, right? But if you look at this, so on the side here, you see like bisphosphate-associated osteonecrosis of the jaw, or atypical femur fracture with 8 years versus 2 years of therapy, kind of equivalent to dying by murder. Right? Let's put that into context, right? The probability is low. But look at the bottom line. If you are high risk for fracture, goodness, right? And we know that can be catastrophic and life-changing. And so in those folks, it may be really reasonable to keep them on longer. 74-year-old female complaining of right thigh pain, otherwise healthy. She's been taking alendronate for 8 years. No recent trauma or activity to explain the pain. No bruising or deformity of the leg, normal gait. How should we evaluate or treat her pain? Try acetaminophen for a week. If symptoms don't improve or worsen, return for further evaluation. Get a right hip x-ray, get a right full-length femur x-ray, or get bilateral full-length femur x-rays. Okay, I hear a D. I like D. D is a good answer. So, what are the symptoms of an atypical femur fracture? So, again, I think if we're, informed consent, tell people to watch for this. So if they've been on prolonged bisphosphonate therapy or denosumab, they are at risk for an atypical femur fracture. And you want to get the bilateral full-length femur films because about a third of patients can have bilateral findings. And so you're looking for this beak-like cortical thickening. But if you don't see it and you have a high enough suspicion without another good explanation, it's reasonable to get a CT or an MRI. And then if there's any evidence of an atypical femur fracture or one that will happen, I mean, some are not clearly going to be subtle, but if this is a suggestion that this could happen, then, referring to our orthopedic colleagues, tell them to be, minimal weight-bearing or non-weight-bearing, get them off the medicine that is the offending agent, calcium, vitamin D, and then they'll see ortho, and ortho may just tell them conservative therapy. That might be all that you need to do, but they may need to pin it or do some other stabilization depending upon the fracture. That's out of my realm, but I would know to refer. 7-year-old woman here for post-hospital follow-up after undergoing surgical repair of femoral neck fracture, occurred 4 weeks ago after a fall. Recent DEXA demonstrates osteoporosis of the hip and spine, which has never been treated. What would you recommend at this visit? Start a bisphosphonate now. Avoid bisphosphonates as it may impair healing. Wait at least 6 months after fracture to start a bisphosphonate. So I'm going to say start it now. Yeah?
Is it helpful to know in situations like this what caused the fracture in the first place?
Yeah, that's a good question. I think that's a really good question. So a fragility fracture, just so we define a fragility fracture is a fall from standing or that level of trauma that leads to a fracture. If somebody has a huge high impact MVA, that's not considered an osteoporotic fracture, but especially in our patient population, especially our older patient population, I think as primary care providers, the thing that gets missed the most and the most good we can do is take a moment and make sure they've been screened for osteoporosis. And if present, and that fracture, regardless of whether it was an MVA or not, now we know they have osteoporosis and they're at risk for other fractures. I think, it used to be when I would get the hospital discharge summary and I see like ankle fracture or or wrist fracture, I'd be like, oh good, they're following up with ortho. I'll see them when I see them, right? And now I'm like, have they had a DEXA? Should they have had a DEXA? Do they have osteoporosis? Should I be treating them? And so I think we can actually add a lot to their care by keeping that in our minds. Does that help at all answer that question? I'm not sure if okay. So I think it's just for me, again, it's a moment of time out and trying to think comprehensively about the patient and whether or not they have been screened. And so, we know that especially with hip fractures, that they are at increased mortality when you've had a hip fracture, and they are also at risk for future fractures. And so trying to treat them and decrease that risk is helpful to both decrease fracture risk and all-cause mortality risk. And so, after the 2-week mark, there's really no difference in delay and healing, whether you wait longer or start right away on a bisphosphonate. And most of our patients aren't going to get out of the hospital and see us within the 2 weeks, right? Most of the time. And so in your follow-up visit is an appropriate conversation and usually an appropriate time to get them on treatment if necessary. And so if that was a typical femur fracture in the setting of a bisphosphonate use, and it's been less than 5 years, assuming they've been adherent with the medicine and we think that they are absorbing it, then you'd probably keep them on it. If it's an atypical femur fracture, then you have to think about whether or not they need to come off that medication because it may have triggered it and switch to a different agent. All right, drug holiday. So when you get to that 3 or 5 year mark with your bisphosphonate, what do you do next? So you first take your time out, reassess their risk, and that can be using the DEXA scan or thinking about whether they have continued to have fractures or seem to be still very high risk for fracture. They'd be in the high risk category. And as we talked about before, maybe a drug holiday isn't justified and you would treat longer than the 3 or 5 years or switch to another agent and then maybe back to a bisphosphonate. If they're moderate risk, then you could consider drug holiday after 5 years of oral or 3 years of IV or switch to another agent. Low risk, sometimes we wonder should they have even been on treatment at all. And I think we're seeing less of that, but in the past we used to see a lot of folks on bisphosphonates with osteopenia to prevent the development of osteoporosis, but I think that's not happening as much. So how do we monitor a drug holiday? These are sort of expert recommendations. It's still not totally clear. There are different ways to think about it. You could do a DEXA again every few years, trying very hard to use the same machine. And if they have continued bone loss, like greater than 5% or more of bone loss over a couple subsequent DEXAs, you may restart. You could use the FRAX calculator. You could just go the 3 to 5 years and then start again. If they have any new fracture, you may start again, or using biochemical markers of bone turnover every few years. And when they start creeping back up, restart therapy. I'm not going to spend much time at all on estrogen. I mean, I think that it isn't first-line therapy. I think most people who are using estrogen are folks that are, just postmenopausal or perimenopausal, and to sort of try to prevent the development of osteoporosis. And in some folks, this may be the safest option for them. But again, not a first-line agent, and a lot of potential risks, as we know about with estrogen and progesterone. Same with SERMs, really only work at the spine, and so if you have hip issues, not going to help that much. But if a patient does have, either has a history of ER-positive breast cancer and or is very high risk, this might be a good medication for them to start with for a period of time. Thinking about the risks of hot flashes, venous thromboembolism, strokes, so on and so forth. But again, once it's stopped, you have to have your follow-up plan. And then what about monitoring response to treatment? This is also kind of conflicting. And so there is some data that says that regardless of reduction in fracture risk happens regardless of the gain in bone mineral density. It seems like the more bone mineral density you gain, however, the better it's probably going to work for you. So you could consider doing a DEXA scan a couple years into therapy. And if you are going to do a DEXA scan, how would we use that information? I think first is to see, if somebody's declining on their bone mineral density, on a bisphosphonate, I would wonder why. I think adherence is a really good question, because about 50% of patients will not be on their oral bisphosphonate a year after you prescribe it. And so checking in on that regularly. So is it an adherence issue? Is it a malabsorption issue for some reason, or they have some other malabsorptive condition, or the medicine's not being absorbed appropriately? So is it not working, or is there something else that's going on that's accelerating their bone loss? And so I think it's more to find treatment failures than it is to find treatment benefit per se. So take-home points. So when you're choosing your medication, think about whether they're high risk or very high risk for fracture. If they're very high risk, we might think about Romo or the parathyroid analogs to start with. High risk, bisphosphonates or denosumab are generally your first-line agents. Moderate risk, probably shouldn't be treating them in the first place. Consider your adverse effect profile, contraindications, cost, ability to actually administer the med, and then any secondary benefits, which is really breast cancer reduction with the SERMs. And then don't forget that concept of consolidation or follow-up therapy after you discontinue some of these. And that's it. And this is just sort of a table of kind of the relative reduction in fracture risk at these different sites for these different medicines. Whew, that was a lot. I hope that I did not talk too fast. Does anybody have other questions that I will do my best as a primary care provider to answer? Yeah.
Is it wrong to start an older woman documenting compression fractures on an X-ray? Wrong to start somebody like that on a bypass without waiting for the next results? If you have that documentation.
Well, I think that, so a couple things. I mean, I think, this is not an uncommon finding, right? And so those are not sort of clinically significant compression fractures. They're compression fractures that were noted incidentally. And so we don't know how long ago those happened. And so one question, when your patient has a fracture, if it's been within 2 years of their fracture, they're at much higher risk of another fracture than if it's 5 years or longer since their fracture. So some of the urgency may depend on that, right? Like, so how recent are these fractures? I think clinically significant that are painful or causing, disability probably, better to get those treated sooner rather than later. However, I would say it's almost not urgent to treat this, right? To treat osteoporosis. And I would feel more comfortable to have data of the DEXA first, because maybe the T-score is minus 3.5. And then maybe that is the patient that I want her to have a couple years of parathyroid analog or Romo first, and then transition to the bisphosphonates. And if I do the bisphosphonates first, then the parathyroid analog may not be as effective. So I would take the time to find that, unless for some reason you just don't have access to bone density scanning, and then you'd have to make your clinical decision. You also are going to have to probably use that information to argue, some of the other non-bisphosphonate medications to get them approved. Yes? Yeah. Yeah, I might have to get that answer for you after. There's a cumulative dose over a period of time that I just can't remember off the top of my head, that if you have a certain, and I'll look it up and I will stand up here if anybody's interested and give it to you after, but if there's a cumulative dose above whatever it may be, then yes, you're at higher risk than sort of intermittent. I'm sorry, I didn't repeat it. Sorry. So the question was, if somebody's coming in and on the FRAX calculator, they ask about glucocorticoid use, what do they mean by that? And so, is it like a knee injection here, a dose of prednisone there? It's usually more of the cumulative long-term effects of the glucocorticoid than sort of intermittent dosing. And there is, like I said, there is an amount over the year that I just can't remember off the top of my head, that says you're higher risk. So if somebody's getting prednisone a bunch for their asthma or something like that, then yeah, they might be, but most people aren't if it's intermittent. Other questions? All right. Well, I will stand out there for a little bit if people have questions, and thank you all for letting me be here, and hopefully you left with some knowledge, and hopefully I don't fall and break my hip walking off the stage. But thank you all very much. It was great being here.